The earlier we could find your cancer diagnosis, the better outcomes you're going to have, the more options you're going to have for treatment, the less aggressive treatment you're going to need, and overall, the better quality of life. Not seeing it doesn't make it mean that it's not there. So if you don't look, it doesn't mean their breast cancer is not there. It just means that we haven't seen it yet. And it might be good in the short term that you don't know that you have breast cancer and you're living blissfully. But at some point, that cancer is going to become evident, either clinically. At that point, it's going to be much bigger than it would have been if we caught it originally on the screening mammogram.
All right. Well, it's a real pleasure to have Robyn Roth on the show today. Welcome.
Hi, thank you so much for having me. I know we have lots to talk about today.
We have so much. Like you and I had this little pre-chat a couple of
Mhm.
weeks ago because I wanted to prep you a little bit of what our listeners have been hearing and
Yeah.
from other doctors and other specialists in various fields on their thoughts about mammograms. And so
Mhm.
it can be quite frightening. And we're hearing one side of the story. We said we've heard some other sides of the story as well, but I wanted to bring you on to give you a platform as well, because to just get one side, I think, is not really fair. And I also have questions myself. So I sent a lot of stuff out to you and some of the research that was presented to me. And I'd love to hear your thoughts about it. You're a radiologist. You've seen
Yes.
plenty of these scans and you work in
Yeah.
the field. You've been trained. Through the intro, exactly, people know who you are. But before I ask like the first question, is there anything you want to say?
First of all, thank you for having me on the podcast to follow up some of these guests that have been talking about the dangers of mammograms and trying to sell you a new imaging technology that is really not approved to replace mammography. I was hesitant to come on the podcast, honestly, because, right, those loud voices can be so loud, but and the science and like the facts and the it's not very glamorous, right? But what someone else is trying to sell you is very glamorous. So, but I really feel like I need to defend the safety of breast cancer screening as a whole and to really kind of clear up some of the confusion that these people are trying to sell you on. So just to give you a little bit of background about myself. So I'm a radiologist who specializes in breast and abdominal imaging. And what that means is that I spent 6 years after med school learning all about medical imaging, the safety, the efficacy, how we use different types of medical imaging and why. And I read all different types of medical imaging. I specialize, most of my practice is spent as a breast imager. So we use mammography as one part of our toolbox, but that's only one part of it. Then we also use a lot of ultrasound and MRI to diagnose breast cancer at its earliest, most treatable stage. I always say that early detection is the best protection. I read lots of other things. There's CAT scans, there's T scans, we use nuclear medicine. So I am well versed on all different types of medical imaging, and I will read whatever is appropriate to diagnose somebody with cancer at its earliest, most treatable stage. Like, that's my job.
Mhm.
I'm not trying to sell you a mammogram. I don't get money every time someone gets a mammogram, as opposed to some of these other guests that you've had.
To share with you, and as well as the listeners who haven't maybe listened to those episodes,
Yeah.
what they've been hearing. And then maybe we
Mhm.
go point by point, because what I did
Sure.
was gather a couple of different guests that we had and kind of compiled some of their information. But what we're hearing is them bringing out studies and research and quoting them and saying no matter how many mammograms we do each year, the same number of women die of breast cancer. They will quote some studies such as the Cochrane report, which they say is unbiased, government controlled, independent, have nothing invested in anything. They would say that half of the women who were screened with mammograms, this is like 600,000 women, half with self-examination, and basically signed the same thing. The women who got screened, the number of women who die of breast cancer is both the same. So their argument is like, do mammograms really save lives? And so they're throwing this stuff out at us. And then they'll talk about the Canadian breast cancer screening study of 90,000 women. And they would share that only 20 to 30% more are diagnosed with breast cancer. Women who get screened with mammograms have 20 to 30% more diagnosed cancers. And there's probably reasons for this, which you can explain. And then the other part that's very worrisome is the overtreatment, overimaging, over biopsy, when 75% of biopsies are benign. And then on top of it, if it is an overtreatment, or maybe it was a cancer that wasn't really, or a tumor maybe that wasn't really necessary, there's this decrease in quality of life and even maybe duration because she's so stressed. And some of this can lead to heart disease risk. And maybe they don't die of breast cancer, they die of something else. And then a lot of other things, and anxiety, depression, sleep disruption, bone loss. I think all of this kind of spirals out of control. And then they would say 800,000 to 1.2 million women in the US are treated unnecessarily for breast cancer. So again, adding more to this. And then one of our guests would always say that when she's seeing clients who get mammograms every year, they're shocked because they said, I thought I was preventing this from happening. Why is this happening to me? And to be honest, my mother, she was getting mammograms twice a year and she died of breast cancer at 57. I thought, how is that even possible? She was very healthy. She exercised. She didn't smoke. So all of this stuff, and I'm sure people have their own stories, and then you hear stuff like this: mammograms missing 40% of cancers, or especially for the women who have dense breasts. I mean, just it goes on and on. So, and there was one other guest who'd brought some information from the National Cancer Institute that summarized like all the data and says there's almost no evidence showing that mammograms prevent death in the 39 to 49. No benefits outweigh the risks. There was some evidence for women in 50 to 59, but not huge, but solid evidence for women between 60 and 69, and then no evidence for 70 plus. So again, this is all, we can grab studies and look at them. Are they good? Are they not good? Is it old data, new data? I don't know, but I would love for you to share, like, why are we hearing this information, and what is wrong with the information that we're hearing, if from your point of view?
Yeah. Well, yeah, there's a lot out there, and you could sway data, like a lot of the Cochrane data and the Gochi, and a lot of this has been debunked, right? Because you could choose to include certain studies and exclude certain studies. A lot of it's outdated. A lot of this data comes from before we had 3D mammography, before we had digital mammography. So the technology has improved, the dose has decreased. Mammography is the only imaging modality that over decades has had randomized controlled trials showing that there is a decreased mortality from breast cancer. Women who get regular screening mammograms are 60% less likely to die from breast cancer. With all the pointing to mammography, it doesn't make any sense because, number one, I mean, the dose of mammogram is extremely low. I know we talked about this, that it is focused on the breast, but mammography is federally mandated. It is highly regulated. There is something called the Mammography Quality Standards Act of 1992 that essentially ensures that the mammogram dose does not go over 3 to 5 milligray per study. That means nothing to you, but we use the analogy of flying on a cross-country flight. So it's extremely low. It's different types of radiation. This is focused on the breast, but it's to really just drive the analogy of how little radiation there is. And mammography allows us the benefit of mammography that has over other imaging modalities, such as ultrasound, MRI, QT imaging, is that it can detect microcalcifications. And the microcalcifications, in many cases, it is the first sign of breast cancer. It may be DCIS, but I have hundreds of cases where it's really the first sign of invasive cancer. And I want to clarify that DCIS, or ductal carcinoma in situ, is a cancer. No one has ever died of DCIS. And that's just not true, because about 20 to 60% of DCIS, if left untouched, will turn to invasive cancer. And we are not at the point where we know which of these DCISs will turn into invasive cancer. When people talk about overdiagnosis, I don't think it's an overdiagnosis. It might be an overtreatment. And that is a real conversation to have. But knowledge is power. If you know you have DCIS, consider it a high-risk lesion, consider it or stage 0 breast cancers, which is what we consider it. There are risks and benefits to everything we do in medicine. So you really have to weigh the risk and benefit. And it might be reasonable in some low-grade DCIS to watch and wait, to do nothing, right? So it is knowledge that you have this DCIS, this early stage breast cancer. So typically they're treated with surgery plus or minus radiation. And of course, these things have side effects, right? So it might be reasonable to watch and wait. So in these types of clinical situations, we would basically follow you at 6-month intervals. And if it doesn't change, then we keep following you closely. But there's risk associated with that because at some point it can turn into invasive cancer and it spreads. I've seen it in my clinical practice. I know it happens. So to say that DCIS has never killed anybody, like it turns into invasive cancer and it can metastasize. So that is false.
Did you say 20 to 60% of DCIS
Will
can
turn into invasive cancer?
turn into
Yes.
kind of
Yeah.
a wide range because
It is.
well, what I've heard is that 80%, I mean, it's quite bold to choose just a number, like you get range. So if it were 80% does not turn into invasive cancer, well, I guess could be true, but it could be 80 to 40 to 80, right? I mean, it depends. It depends. So in fact, to say 80%, that's only just giving one side of the spectrum. Yeah, I guess it's possible.
Yeah, that's the low side. That's the low side, right? So like DCIS, when we do a biopsy and it comes back as DCIS. So sometimes we'll say low grade DCIS. And those patients might be okay to watch and wait. But when it says high grade chemoto-necrosis, like these are factors that go into like saying that this is not the type of DCIS you'd want to watch and wait on. And we're getting to the point where it's going to be even more individualized approach of how we treat your DCIS. So it's not a one size fits all approach. All of breast cancer is not a one size fits all approach. You have to weigh the risk and benefits of treatment and diagnosis. But knowing that you have DCIS at least gives you the power. You have to look at what's causing this or why you develop breast cancer in the first place. And maybe it's a wake up call to make a change, but you can't cure DCIS. It doesn't self-resolve.
No, I think it was a question of like, just so I understand, because obviously a lot more about breast cancer than I do, is that if it sits in there, it's not a problem. It's just if it starts to get out of the ducts or like ductal, right? This is called the ductals in the ductal parts of the breast. If it comes out, then it can metastasize and then it becomes a problem. And I think the whole weight, I think the way it was cleared up, the wait and watch approach is not just wait and do nothing. Like you wait, clean up your diet and you do some exercise and you try to improve your health. And that maybe for those people, the ones who have DCIS is not going to develop and maybe you die of something else along the way. But the hard thing that I can understand a woman who gets this diagnosis is like, wait, I think there's this fear that we want to just get it out and it's hard to like wait. But I guess it can be, some people have, I mean, I've interviewed other people who said, look, it's just with their experiences as doctors, they said, well, some people are like that. They just like want to get it out. And some people are like, you know what, I'm going to chill. It's going to be, let's just see what happens. And I don't want to be aggressive with this. So I think it's kind of a personalized approach. But I think to be fair too, is like with some of the other guests we've had is like, well, yeah, there's things that no matter what, whether you're getting a mammogram or other type of imaging, if you see something that looks cancerous, you go and get a mammogram. Like there's no doubt that the mammogram is great for diagnostics. I think the argument that they have is, do we really want to use it as a screening tool for women who are perfectly healthy, have no risk, they don't have dense breasts, they have no family history? Maybe there are other options that are better, but again, that's the question. And that's what women are always saying is, and the whole radiation piece, again, that's what I'd like you to explain a little bit more. What is the difference between this scattered radiation that we have in the earth and the planet and like it's low grade, not a big deal, and then the localized that is targeted to a certain part of the tissue? What are those differences? Like, because I didn't have even a chance to even look for studies on what is localized radiation and how bad is that?
Right. So mammography has been safely used for decades. Though, like we said, the dose is very low. Of course, radiation dose is cumulative over time. And we are always doing something called a LARA, as low as reasonably acceptable. So there is a certain amount of dose that you need to penetrate through the breast tissue to be able to see these microcalcifications. Like we use X-rays, which is the one that has the radiation, for all different types of medical imaging, for chest X-rays. Like we don't do an ultrasound of the chest to see see if you have pneumonia, because we just can't penetrate through the tissue like that. Same thing for the breast. We have to penetrate through the breast tissue to see the microcalcifications. You can't see that on ultrasound. You can't see that on MRI. Yes, those have the added advantage of like not having radiation, but they can't see the calcifications that we are looking for. A screening test
I
has to
thought
be
MRI, sorry, I thought MRI can see the calcifications, no?
not see the microcalcifications. It might see some linear enhancement that is associated with DCIS, but some of the early stage DCIS do not have enhancement. They only have the calcifications.
And
And
even with the MRI with contrast, you can't see the
yep,
calcifications?
no, you cannot see the microcalcifications we're looking for. Breast CT is a new and emerging technology that is being used. That is being used by radiology centers. Okay, so it means it's had numerous studies backing it up, and safety and efficacy, and being able that apparently can detect the microcalcifications that we're looking for. I have some concerns about the dose of a breast CT to the radiation dose to the breast from a breast CT, but they say it's only slightly higher. But again, when you're talking about a screening test, you need to have a cheap test that's accessible to a large population that is able to detect the signs, the early signs of cancer. When we get a mammogram, the small radiation dose of a mammogram is justified by the fact that we are able to detect these early cancers. The National Cancer Institute came out and said that any possible downside of the radiation dose to the breast is heavily outweighed by the benefit of early cancer detection. So if you choose to not get a mammogram, let's say you choose to do QT imaging or one of these alternative imaging methods, which a lot of doctors will tell you they don't recommend, you just have to understand what you could be missing. So a lot of these cannot detect the microcalcifications of DCIS and the earliest signs of cancer. It's a false sense of reassurance. A lot of these imaging tests, like thermography, is not approved to replace mammography. It is actually, the FDA will go against anyone who tries to sell it as such. And
Most of
the way
people we've interviewed, they say the same thing. It's an
yeah,
add-on kind of a thing. It's a cool add-on to give more information, but not
it gives
replacement.
it gives you no information, just to be clear. Like, it gives you every so often, I have a patient come into my clinic because they had an abnormal thermogram, and we have to work it up, and it's really a confusing thing. It's most likely nothing, but then I have to follow them because of this thermogram that's outlying. And on the flip side, I have people coming in with a late stage breast cancer. They're like, I don't understand. I've been getting thermograms. And I was like, well, that's the problem. It's a false sense of reassurance, and it's so predatory on people's fear of developing breast cancer, and the fear mongering that goes into like mammography has radiation causes cancer, therefore mammography is bad. So it's really it's been happening over the last few years. I think social media has really played a part in this, of preying on people's fear of developing cancer, and this we've got this shiny new test that doesn't have radiation, so therefore it must be good. But we don't have the long-term data, we don't have the long-term studies, and the safety and the efficacy is not really established.
That's the QT scan. I mean, let's talk about other stuff that you do and that are, because there are doctors out there who say, well, yeah, ultrasound is good, or not that it's, some say it's in addition or it's better. I just listened to your episode with Dr. Daniel Copens, and he's a radiologist. He's the inventor of the digital breast tomosynthesis. And he said, so you're going to have to clear this up for me, because he said MRI is clearly the best way to screen for breast cancer. The next best way is digital tomosynthesis, which you'll have to explain. And then ultrasound, radiomamography. And then the ultrasound. The ultrasound finds more cancers than mammography alone. And this is the guy who invented this digital breast tomosynthesis, which is the enhancing mammography accuracy, which is for enhancing the accuracy of mammography. And so I'm a little bit confused, because he's like saying that
MRI.
No, the MRI, he says, if we did MRI, I think we could cure 75 to 80% of breast cancers before they killed him. So even though he's very pro mammogram, he was saying MRI is better and then ultrasound's better. So clear that confusion on that.
So it goes back to the screening principle. Like MRIs are expensive. They take 45 minutes. They require an injection of gadolinium. Not everyone is able to lay on their belly for 45 minutes in this loud tube. So in terms of feasibility as a screening test, it's not there, which is why we use it.
Yeah, that he did say that. And actually across the board, he seems to be saying that as well. Like it's just not accessible for most people. But if you did, he was saying, well, if you can access it, that would be the best.
Yeah, but it still doesn't detect the microcalcifications of DCIS. It can pick up the enhancement of later stage DCIS, but it's still, I think I tend to disagree with him there, which is interesting because like you said, so digital breast tomosynthesis is 3D mammography, which is the best version of mammography that we have at the moment. What I personally love, I don't know if you're familiar with contrast mammography, which I essentially describe as a mammogram and an MRI had a baby. And it gets all the added benefits of the mammogram, where meaning you can see the microcalcifications of DCIS, but it also has the added benefit of a contrast agent. It's not gadolinium, which is a heavy metal and can cause problems in people with kidney disease. It uses iodinated contrast, so iodine-based contrast, and it's the same type of contrast we use in CT scan, so it's usually better tolerated, and it really overcomes the limitations of dense breast, and it allows us to see if anything is abnormal. I personally would love to see contrast mammography being used in the screening population in women with dense breast tissue, because I think that is really it has all the added benefits of every imaging modality combined, and it's quick, it's cheap, it's under 10 minutes, it's covered by insurance. It's not being used in the screening setting at the moment on these populations, but we've been using it at my institution since 2011 in the diagnostic setting in the high risk or the intermediate risk patient population that has dense breast tissue.
Does it stop the breasts too?
It does compress the breast. And I'm surprised. It's so interesting how everyone is so concerned about the breast compression, because the breast compression in a mammogram is really essential because it minimizes the overlapping tissue. And it allows us to see through the tissue a little bit better. And it also, that's really the main thing, is that you need that. And you also limits motion so that there's not a lot of motion artifacts when you're getting a mammogram. That's why compression is necessary. I mean, I think it's over exaggerated by people. I know that a lot of people try to avoid mammography because they don't like the compression, but like I've had several mammograms. It's uncomfortable for 30 seconds or less, and then it's not a problem. I don't know. I know that there's been lots of the damage to the breast. I haven't seen that to be true.
And if someone
there's not been really studies to elucidate it. There's not been studies to elucidate that.
And what about she has implants? Is that any more difficult or painful? Or
we basically do two sets of images. We do ones with the implant in, and then ones where we push the implant out of the way and squeeze the anterior breast tissue. So if you've never seen one, I have a video about that coming up soon.
So okay, then
but
go ahead.
Yeah, sorry.
I was just wondering,
that
the doctor you had on your episode when he was saying MRI, if he were to say MRI is better, then he's not recognizing the fact that it doesn't pick up microcalcifications, or he doesn't think microcalcifications are important, or why do you think he would say that?
He definitely thinks I don't know why he would say that. He definitely thinks that microcalcifications are important. I mean, like I said, it can pick up more of the higher grade DCIS. So maybe he's saying that the low grade DCIS isn't a problem. MRI is usually used as a supplement. Ultrasound and MRI are used as a supplement to mammograms. In patients that have dense breast tissue, MRI is usually reserved for people that have a greater than 20% lifetime risk of breast cancer, but that is becoming less of a problem because there's things called abbreviated MRI where you can get a quicker, cheaper MRI, and this is better for the screening test, for a better screening tool for the general public, but it's always in addition to your mammogram, and that's because of the microcalcifications. I do believe that Dr. Coppens thinks that microcalcifications are important. He invented mammography, and
It's funny how a
Yeah.
guy who invented mammography says MRI is better, like, or ultrasound's better. Like, I was surprised. I was like, why would he say that? But I'm wondering then the whole argument with the with the mammograms as well for women with dense breasts
Mhm.
is that it's like finding a snowflake in a snowstorm, and there's
Yeah.
40 to 50% of the women in the planet who have dense breasts. And
Yeah.
then if you're on HRT, then that can also increase the density. So yeah, how do you overcome that?
Yeah, so the sensitivity of mammography is like it's quoted as 87%. It gets a little bit lower when you have dense breast tissue. It's very reader dependent. So if I'm reading your mammogram versus a non-board certified breast radiologist that's just general practitioner radiologist, we're going to have different callback rates and different sensitivities in dense breast tissue. But it definitely is lowered. It's quoted as like 50 to 75% in women with dense breast tissue. So I like to describe it as breast cancers are white, and so is dense breast tissue. So the more dense breast tissue you have, the harder it is to find a single snowflake. Like it's like a blizzard. Then it's harder to find a single snowflake in a blizzard.
Mhm.
So the dense tissue makes it a little bit harder. It also increases your risk of developing breast cancer. So now we know that dense breast tissue, it's kind of like a double-edged sword. It makes it harder to find small breast cancers using a mammogram alone, and it also increases your risk. So when we add,
What do they find if you're in a moment dense breast? What's the whole
yeah,
point of doing a mammogram if you can't see
right.
that?
So it's really good still at picking up calcifications. It's not great at picking up masses that can be obscured by the dense breast tissue, but it's really good at picking up the microcalcifications. That really is not affected by the breast density because we can see breast calcifications well, even in women with dense breast tissue.
So you're getting the mammograms for the calcifications, and then you're getting
Yeah.
ultrasound to see if there's a tumor, right? Or
To see, well, you're getting the ultrasound to see through the dense breast tissue to see what there's masses on there. And I personally have dense breast tissue. I'm intermediate risk. I get a mammogram and an ultrasound. Once we add an ultrasound to the mammogram, the sensitivity rates are about greater than 95%. So it's very sensitive imaging test when it's done together, especially in women with dense breast tissue. It's mammography alone, though, is great in women with fatty and scattered tissue. If you do have dense breast tissue, you might want to consider adding a supplemental ultrasound or MRI or QT imaging test. I'd be okay with that as a supplemental imaging test. Now, for the people that really just don't want to get a mammogram, they think that they cause cancer, the compression, they have all these issues with it. You can get just an ultrasound or an MRI. You could choose to do that, but you just have to know what you might be missing, which is we might not be able to see early signs of cancer. So I think you just have to understand what you are not getting by not getting a mammogram.
what do you
Um,
think then of so if there's a person like that listening, and I'm kind of
mhm.
likening this whole argument with the mammogram very similar to HRT, which is why I'm asking you to
Mhm.
come, because we were all scared HRT is causing cancer and we're worried, and now it's been debunked and now we're embracing it. And I'm
Yeah,
like, what if we're missing something here? What if we are going on old data? What if mammograms really do save lives, and
I
we're just
definitely.
kind of stuck in this old school of mammograms cause cancer kind of a thing. And so we have to, what I say the same thing when women are cannot HRT causes cancer, totally convinced in her head. I will never
Mhm.
talk about taking HRT to her because I just think it's programmed in her head. And
Yeah,
there's probably dangers for her. Like, who knows what's going to happen? Without the thoughts in your head can sometimes manifest. So I know it sounds woo, but because of course cancer starts like years and years, decades could be before it develops. But I'm wondering for the woman, like if I take that approach with the woman in HRT,
yeah,
then I have to respect the woman who says, look, it's really not for me for XYZ.
absolutely.
But we know that she shouldn't. Maybe she still agrees. Like I should screen my breast somehow. What's
Absolutely.
best, like the next best thing in your opinion?
Listen, I think it's fair to hear someone out and to have like listen to them why they have concerns, to try to tell them why those concerns are not valid, that mammography has had decades showing that it's mammography has helped decrease mortality from breast cancer by 40% since the 1990s. There's been many randomized controlled trials showing that it's caught like lessen the mortality. Women are less likely to die from breast cancer if they get routine screening mammography. It's not the mammograms. And I'll tell you why I know this is true. Because we have a rise in young breast cancer. Most of these people have never never had a mammogram in their life. I have many people who walk in on their first mammogram at age 40 have breast cancer. So it's not the mammogram that's causing the cancer. If anything, the most recent data from the American Cancer Society show that cancer is declining in the older population, so greater than age 50, and it's increasing in the people under age 50,
What
with the
about these
highest
studies?
increase.
Like, what do you say about the studies that they have? I shared some of the stuff that I found from our
Yeah,
guests. What
yeah, they all use the same
studies aren't
studies that have been
anything supporting
debunked.
any argument. So, what are they presenting to us compared to what you?
Yeah, I mean, the Cochrane review, it's like they keep showing the same study. I think it's very outdated. It's over 20 years ago. And it's by a guy who the Cochrane review came out and said that he has completely violated all of the principles of the Cochrane review. And he chose to leave out important key studies and only choose these studies to validate his points. He also then went on to write something about vaccines. So I think this just gives you an idea of who is writing these articles and who his people that he's talking to are. I think it's very easy to find people to support your whatever opinion you have, but you have to look at all the data, and all the data is points to the mammography saves lives. Mammography allows us to find breast cancer at its earliest, most treatable stage. When we find breast cancer at stage 1, stage 0, you have a 98% chance of surviving for breast cancer. That number goes down significantly when you are diagnosed at later stages, which is why annual screening mammography saves the most lives, period. End of story.
But what about the National
It's
Cancer Institute? That study, or
I'm
or
not familiar with that study, but you'll have to fill me in on that one. But the
yeah.
National Cancer Institute specifically came out and said that the benefits of screening mammography far outweigh any potential risk from the radiation from mammography.
Okay. Well, this was the one that where she quoted no significant for women 40 to 45, slight difference saving lives in for women 50 to 59, and then none. I can't find it. Oh yeah, here it is. So some evidence for women 50, 59, but not huge. And then there's solid evidence for women getting mammograms preventing death between 16 and 69. She brought that out from the National Cancer Institute. And I was like, oh, well, that's pretty believable. I mean, unless there's
There's
some
a
other.
study, there's been a big randomized control study in women ages 40 to 49 showing that there was a mortality benefit in those women as well. So I just don't have those numbers on me, but I can send you the data on that. But there is significant, I mean, that we are seeing the amount of people that I see coming in their 40s. Like I've been keeping tabs for my first quarter. I just want to pull up these numbers, but basically women 30 to 40, it's like 11 women 30 to 40 who've never had a mammogram, first mammogram, 11 women in their 40s, 40 to 49, many have not had many mammograms, 11 women in their 50s to 60 to 75, and then another 12 women in their greater than age 75. So it is a wide range of people that I see in my clinic. They all have had varying amounts of mammograms. It's not the mammograms. This is because a lot of these people have never had one. And like I said, we're seeing a rise in young breast cancer. Most people who are diagnosed with breast cancer do not have a family history or genetic mutation, which is why when you said something about why are we screening an asymptomatic population that may not have a family history, most people do not have a family history of breast cancer who are diagnosed with breast cancer.
That's surprising. Seems like everybody knows somebody. Well, everybody knows somebody, maybe not in their family, but it hits so close to me because that's
Yeah.
my own history. But I'm wondering that. So I think the real elephant in the room that we should always bring up whenever we're having these discussions, whether it's about hormones or mammograms, like what really causes breast cancer is other things, right? There's obesity, there's the diets that we're having, there's a lot of other things, the smoking or drinking alcohol. These are all high. We're at a much higher risk, I believe,
Yeah.
by having the excess body fat or drinking that alcohol that we probably shouldn't, the excess probably. Again, well, there's some people have zero tolerance, depends where you go, but those are the real things that cause cancer or contributes, or it's not causes, but increases our risk of breast cancer. And correct me if I'm wrong, but like, what are the top 3, let's say 3 or 4 things that increases our risk for breast cancer?
I think that there's so many, I think it's multifactorial of why we're seeing this rise in breast cancer. I think it has to do with our sedentary lifestyle and lack of exercise, alcohol and vaping being so widely accessible, our diet that is very rich in processed foods and low in fiber. So I think those are the big things, like you said. But then there's lots of things that are out of our control. There's certainly something in the water. There's something in the environment that we have no control over, right? Because if you say it's just those three things, that's kind of placing blame on the person who develops breast cancer and being like, you drank too much. Like, it's not that. We have people that are perfectly healthy, vegan, run marathons, and they get diagnosed with breast cancer. So it's not just one thing or three lifestyle factors. We don't know. We don't know why we're seeing.
It sounds like when you see environmental could be pollution, it could be pesticides, it could be the microplastics, it could be the stuff in our skincare. You know, where women are putting on tons of stuff on our, I mean, me included, or shampoos and lotions and potions. And so it's that environment, as I understand, like genes plus environment plus a trigger, and that equals disease, right? So you may have a genetic predisposition, but even if you don't have the genes, like you said, there could be some environmental factors and then some kind of a trigger. But the toxicity, that's an important one. Yeah, go ahead.
I think that it's really, I am a strong believer that like you can't prevent cancer. You can lower your risk significantly, but you can't prevent it. And I think that some of your prior guests, like I've heard, like if you have a cancer diagnosis, then we have to look at why you have this. Is it your toxic relationship? Is it your alcohol? Is it you're not working out? And I really think that places blame on the patient, and it's not always something identifiable that they did. Certainly, it's a chance to optimize your health, but it's not something that we can go back and say, oh, it was the alcohol. And I think that's a really dangerous, it's important for anyone listening to know that breast cancer is not their fault. And it's nothing that you did wrong that caused your breast cancer.
Definitely. But the whole prevention thing is something we can control, right? And we can try. There's no guarantee.
Prevent is a hard word for me because like I said, you can do everything right and still get breast cancer. So I like to say risk reduction.
Yeah. I say exactly the same thing as you when I'm talking about HRT, because we throw around these words, it protects your heart, your brain, your bones. And I'm like, wait a second, there's no guarantees that you take HRT and what, you're going to leave everything else out the window and not do it. It will lower, likely, maybe, our risk for certain diseases. So what you're saying is actually makes perfect sense to me, in the sense that we can try to control as much as we can. I mean, without going crazy, or it's a good idea to quit smoking. I mean, it's a good idea if you can and you want to try. If prevention or lowering your risk, if lowering your risk is interesting to you, then it makes sense to say, you know what, now is a good time to clean up your diet, your lifestyle, and look at some of these things. You're going to probably feel better anyways. That may lower the risk. But also, I don't know if you're seeing with your clients or in your population and community, the women who do get diagnosed, and then they do say, look, I'm going to now really clean up my diet and lifestyle, and I'm going to try to be the best version of myself, no matter what the outcome. Are you seeing any changes and any differences between those people and those other people who are like, it is what it is?
Yeah, certainly. Like exercise, eating a healthy diet, all these things will help it will help lower your risk of recurrence. It will help improve your outcomes. It will also lower your risk of dying of heart disease, which is more likely to kill you anyways. So like all these things for general health, like I do feel like we have to look at our whole health. All these factors go into a healthy diet, and certainly cancer may be a manifestation of something going on in the body, but it all plays into our overall health. So all these things are good ideas when, no matter where you are if you're before a diagnosis, after a diagnosis, currently going through cancer treatment, it will improve your life overall in general.
What about, so there's, going back to the radiation thing, because I still haven't quite wrapped myself around what it sounds like when you do something in focused, intentional radiation on a direct, I don't know, part of the tissue, then it would be like a death out of 1,000 cuts. Maybe once it's not a big deal, but what about the woman who is getting the mammograms, like me, since I've been in my 30s, because my mother died when I was only 23. So I've been getting mammograms. I've probably had 15 of them already by now. And I've had x-rays, and I've had knee x-rays, hip x-rays, dental x-rays. I travel like there's no tomorrow. So I can imagine somebody like me, or even probably worse, who's got so much accumulation, that is there ever a point and you kind of go, maybe it's enough, maybe it's too much? Because whenever I get a mammogram or an x-ray, I'm like, I see that big old danger sign on the wall, and then everybody runs out of the room. And I'm like, why are they running? Is it really that bad? I mean, so you feel
Mm.
like, oh my God, I'm like a sitting duck here. But, where's the point where you go, you know what, maybe it is too much?
Well, if you're going every year for your mammogram, hopefully you will benefit from the early detection of a mammogram, right? Like so that it will be caught early. I think that there's not a point where you're like, okay, I'm done. I've had enough. I mean, that's a personal choice, but it's not like I've hit my cap on radiation, so I have to stop getting radiation. There's still a benefit. I mean, certainly like we talked about, the dose of a mammogram is low, very low. Certainly coming every year, it's cumulative, but it's still within, again, the point is to find breast cancer early. I don't know how to kind of debunk, like, right? So when you're in a radiation room, the tech who's exposed to radiation 20 times a day is different than you, who is getting this once a year, maybe twice a year. So it cannot be considered the same thing, right? Like if I was exposed to radiation every time somebody in my office got a mammogram, that would not be that would not be a healthy way for me to live, because right, radiation, yeah, we want to minimize exposure to radiation whenever possible. But when you have an imaging test that has been shown to save lives, find cancer early, gives you better outcomes from your breast cancer diagnosis, then the small dose of radiation outweighs the benefit of that, far outweighs any potential risk. I don't know how to alleviate your fears anymore other than saying it's an extremely low dose. It's been used for decades. And it's like I said, it's if it was the mammograms, we would be seeing all these women in their 60s and 70s developing breast cancer. And that is just not what we're seeing. We're seeing lots of women coming in from their first, being under the age of ever getting a mammogram and still coming with breast cancer. So to blame it fully on the small amount of radiation dose from a mammogram, it's irresponsible. Like it's not where what we're seeing in clinical practice. In theory, I get what you're saying, that like radiation dose.
On top of everything else, let's just say,
Yeah.
on top of all the other radiation exposures they've had, on top
Yeah.
of maybe a bad diet and lifestyle, on top of like, nobody's
Mhm.
perfect here. So,
Yeah.
so you can think of all the pollution and all the toxicity that we're having. Like, do we need to add more to the bucket when we have alternatives? But what you're saying is that the alternative is not so as good as actually the benefits you'll get from a mammogram, if I
Yeah,
understand.
I mean, maybe you say, you know what, mammogram's not for me right now. I'm just going to get ultrasound or an MRI. That might be fine. I just want you to understand that we might be missing DCIS and some of these newer things. I know we touched on QT, but like QT imaging is not made to detect the axilla. It doesn't image the axilla and the chest wall, and that's where breast cancers can develop. So I think you just have to understand what you could be missing with the imaging test that you're doing instead of a mammogram. And I do think that a mammogram is part of your breast cancer screening. I am a really strong proponent of a monthly self breast exam because we talked about mammography is not perfect and things can pop up between one mammogram to the next. They really truly can be a truly negative mammogram and have a cancer that pops up 6 months later that wasn't there before. So things can pop up quickly, which is why I really encourage everyone, especially because, like I said, we're seeing a rise in breast cancer in younger people who are not being screened, that these people really need to take their breast health seriously, get to know their breasts. If you notice a change, you certainly want to pay attention to it and get an appointment with your doctor as soon as possible. And then that is an appropriate time to do imaging. Certainly, if you find something
Yeah,
that
yeah.
is worrisome, we definitely want to do a diagnostic mammogram and an ultrasound. That's a different type of population than a screening. Screening means you're asymptomatic versus a diagnostic means you have a complaint that we are going to evaluate.
Mhm.
You might be one that says, I'll get a mammogram when I feel something wrong. But the point of mammography is to find something before you actually feel it. Once you feel it, it's large. It is probably already involving a lymph node. So mammograms can really detect breast cancer way before you have any symptoms. So that's the other important thing to know. But I do think it's all part of your breast health.
I heard though that one of our guests also said that if you can feel it, it's already big. It's not like it wasn't shouldn't say
Yeah,
it's like too late, but it can't really depend on just your touching your breast because
absolutely
it's
not.
going to be already big,
Absolutely.
right? So
Yeah.
what are the
Yeah,
chances
I
of?
think it goes in. I think it goes in hand. Like it needs to be part of your. I do an annual mammogram, and I always do a monthly self breast exam as well. It has to be part of it as well.
So then what are the chances if somebody says, okay, I'm not going to do this and I'm just going to do self-exam or I don't know, whatever she decides to do. Once she finds something, what are the chances of survival if once she goes in, gets a diagnostic and then goes, well, we found something. Is it by the time you find it, it's already too big that like 50% of the women die? Or, I mean, is there a number?
So, I mean, it depends on the stage that it ultimately is diagnosed at, right? The survival rates go down the later stage that you get, but it's not 50%. It's more like on the range of 60%. Even at stage 4, it's like 60% survival at 5 years. But going compared to the 98% that you can get when you catch your breast cancer at the earliest stage, maybe the small radiation dose wasn't so bad after all. Like now you're going to have to go through more aggressive, right? Not only does mammography improve your mortality, but it also lowers the chance that you're going to need more aggressive treatment. So if we can catch your breast cancer early, we may be able to potentially avoid chemotherapy or lymph node dissection, or in some cases, radiation. So all these things have side effects. So, the small dose of a mammogram that you might get that might catch your breast cancer at an earlier stage may potentially avoid you having to get radiation therapy to your chest wall down the road because you got late stage cancer. So I think we have to look at it in terms of the big picture as well. And in terms of like quality of life, when you are caught with early stage breast cancer, your quality of life is going to be so much better than somebody who had to have lymph node dissection, chemo, all these more aggressive treatments that may have been potentially avoided if they got routine screening.
So when somebody gets an early diagnosis, then and what are the options then? How do you treat it through what?
Yeah. So breast cancer is one term for thousands of diseases. It really depends on the invasive. Is it ductal? I mean, is it in situ? Is it cancer that's localized to the duct, or is it spread outside the duct? And how far has it spread? And then also we talked about the receptors play a big role in it. So is it invasive? Is it ductal or lobular? And then also the types of receptors that it has. Does it have estrogen and progesterone receptors? Does it have HER2 receptors? So all of this really depends on the size, the receptors that it has, the grade, how far it's spread. So, if it's caught early, if breast cancer is caught early, we may be able to treat you with just surgery. If you choose, when you talk about surgery, it's usually lumpectomy, where they take out a portion of the breast, versus mastectomy. When you have a lumpectomy, oftentimes, not always, they will add radiation on top of that. That is a conversation you have with your oncologist to decide if it's worth the lowering the risk of recurrence that you will get from the added radiation. Again, it's weighing the risk and benefits because radiation does have side effects and it can cause heart problems down the road. So these are all things that we have to weigh. But as opposed to so surgery, radiation, if you catch it early. Now, if you catch it later stage, let's say it's now, 2.5 centimeters and it's gone to a lymph node. Now you're talking about potentially having to add chemotherapy on it to shrink it first before you can go to surgery. So now you add chemotherapy to this regimen, which is not pleasant. It has its added benefits of lowering, that it's already, the cat's out of the bag once it's already in the lymph node. So you're getting those cancer cells that may have escaped, but you may have avoided that if we were able to catch it early. In some cases, you still need to do it. And then on top of that, we might add hormonal therapy or immunotherapy. Like there's all these different types of therapies that we might have to do if somebody is more late stage or has a more aggressive subtype of cancer, like triple negative cancer. So all these go into play. But, if we catch your breast cancer early, we may be able to avoid the chemotherapy, the lymph node dissection, some of the other therapies that go along with breast cancer treatment, and you'll just have better outcomes overall.
What are the percentage of women who do catch it early enough then can avoid all that stuff? Like, what are you saying?
It's hard to answer that question, but survival, when you are diagnosed at stage 0 or 1, it's like a 99% survival over 5 years. That number significantly decreases as you get to later stages.
Yeah, but that survival, this was another argument that one of our guests brought, is that the survival rate was sort of biased. So that means a woman who is diagnosed with breast cancer at 40 and then she survives 5 years, she's counted as survived. But if she dies at 6 years, it's not. So you just need to make it to 5 years. But if you made it to 6, then it's not really counted. Am I understanding that right?
With
and I
survival
asked, I said,
rates
well,
for
what is it? What is like, what
like
would you consider a survival rate? She's like, I would be like 20 years. It would be, for me, I would count survival. I
right.
wouldn't count 5 years as a
I
survival.
mean, I guess there is like an age bias, right? So if you diagnose someone younger, they're more likely to survive from all things. They're less likely to die overall. So I do think that there might be like an age bias, but even 10 years, 20 years out, I don't know the numbers exactly, but it's always going to be better if you diagnose your breast cancer early. Like we're not talking about 10-year survival rates. We're not talking about 20-year survival rates when someone with stage 4 breast cancer, unfortunately, because a lot of them won't make it, but most people will with stage 0, 1, 2 breast cancer. I don't
Yeah,
have
so
those
there's
numbers.
there's the survival thing, which is
Mm.
great. But then there's the argument of all this suffering that happens during those 5 years because she's stressed, her life is completely shifted, she can't get her mindset in the right place, and then she sleeps poorly, and then she starts to gain weight, and then she gets heart disease, and then she's got all these other problems because of the stress from the diagnosis. But again, if that would have killed her in the end, maybe it would have been better to go. It doesn't matter, but
Mhm.
I don't know. It's the quality of life that you wonder. I mean, when I was just given birth, I had to get a biopsy because I had I felt a little lump, and I was like, oh, it must be blocked milk duct.
Mhm.
And they took a biopsy, and I was waiting. So over Christmas holiday, I had to wait, and it was horrible waiting. I was like, my mom died, because they looked at me. They're like, well, do you have anybody in your family with with cancer? I'm like, yes, my mom died. Like, why are you telling
Mhm.
me these things? And the stress. Then in the end, they said, you know what? We need to do another biopsy. We didn't get enough. And I was like,
Mhm.
forget it. And that was stressful enough. I just had my
Mhm.
second baby. I was like, I'm not going to see my kids grow up. I'm going to probably die. And it turned out to be nothing. I got another biopsy and it was fine. But it was just, I experienced a little bit of that stress, and I cannot imagine if it was something much bigger. So, and that was only just for a period of 3 or 4 weeks. But if you're going
Yeah.
months and months, the stress and the damage that's doing, because the thoughts in your head must be so bad. What do we say about that?
Well, cancer is stressful, number one. Cancer scare is stressful, but being diagnosed with late stage cancer is also stressful. Like, I do feel like after you had that second biopsy and we found out that it was all normal, do you carry that stress around still? Like, are you still like anxious? I don't
No, it's
know.
not
Like,
the
I
same. When
do,
people say you're fine, you feel better, but when it's that wait
right.
period, and that's
Yeah.
nothing compared
Yeah.
to what women go through and have to go multiple times to the doctor and this scan and that scan and what is it and how are we going to treat it and all those decisions that you have to make. Do I cut my breast off? Do I not? Do I keep it? Like, I cannot imagine, and that's a real thing. So I
Yeah, but not knowing doesn't cure the stress. Like ignorance is not bliss. So knowing that you caught cancer, but at a treatable stage, should be empowering. I know that the process is awful. The waiting for we give results in 3 business days, but certainly those 3 business days you are walking around really thinking like you have cancer. But hopefully after the biopsy, most of the patients say the biopsy wasn't that bad, and I always tell them the waiting's the worst part. Like I wish there was a better way. But most people will get a diagnosis of either it's benign or it is cancer. But if it's benign, they could usually move on past that event. It's not something that they had this scare, it was stressful for a short period of time, but then it was resolved. Now, the person who's going through cancer, it is stressful. Like there is no way to sugarcoat that. I don't know how to, but not knowing that they have cancer doesn't make the cancer go away,
Mhm.
right? Like you're just living longer without knowing you have cancer. And yes, it might be better for a short period of time while you're living in bliss, like you think I'm just healthy.
Mhm.
Meanwhile, there's a cancer growing inside of you. Once it's finally diagnosed, I don't think it's less stressful than it's more stressful, perhaps, because now we know it's late stage. That I don't think eventually you have to know if you have
I think it'll
cancer. Maybe you
depend on
don't
the
have to know,
person.
but
Yeah, some people
yeah,
understand too. My husband had cancer when he was 33 of thyroid, and he was like, I don't know, it was like not a big deal. Like, he did not even phase him. I would be
yeah,
freaking out if I were 33 until I had thyroid cancer. But it's his attitude, and he's kind of a
Mhm.
fatalist. It's like, well, we have to die of something someday, kind of a kind of an
Right.
attitude. So it probably depends. But I'm wondering then, what is the statistic of, or at least because I do see agreement somewhere on the
Mhm.
overdiagnosis, like that
Yeah.
happens overdiagnosis and overtreatment. Like what are
Yeah.
the numbers there? Like how many are overtreated when maybe wasn't
Well,
quite necessary?
it's hard. We talked about with DCIS, when you're talking about overdiagnosis or overtreatment, I think most people are referring to DCIS or ductal carcinoma in situ. We talked about the 20 to 60, I think it's 25 to, I have written down 25 to 60% will turn into invasive ductal cancer. So somewhere between 20 to 60%, I would say.
Mhm.
It's not small. We don't know where you are in that spectrum. Like we talked about, that it might be reasonable to watch and wait, but I do think that there is a risk associated with that. I think people have to understand the risk that they could be on that 60% range, and they could be the ones, unfortunately, that do turn into invasive ductal cancer. In that case, I just think that I think overdiagnosis, I think overtreatment needs to be used instead of overdiagnosis, because knowledge is power, right? Knowing you have stage 0 breast cancer, which if left untreated, a lot of them will turn into invasive cancer. That is knowledge that you choose to do nothing with. Yeah, it might be stressful knowing that you have it, but I don't know that not knowing that you have it not knowing that you have DCIS doesn't make it go away.
Mhm.
You might be watching and waiting without even realizing it, like with ignorance, not realizing that you have this, but it doesn't take away the fact that you have DCIS. It doesn't self-resolve. Even if you find out you have DCIS, you decide to do nothing except you decide to do nothing except change your lifestyle. You change your habits. That might be a positive thing. That is knowledge, and you chose to do something about it. I think that
But
cancer
it
diagnosis.
doesn't make the DCIS any smaller or less
Yeah,
aggressive or anything. No, it doesn't
right.
go away in any way.
No, and I heard somebody mention on your podcast that DCIS can resolve. It doesn't resolve. That's not what I've seen in my clinical practice. I've had very few patients that have watched and wait, and they usually end up going to surgery eventually. It's a matter of time. And that is a stressful place to live in,
Mhm.
right? Like if I say you have DCIS, it could turn into cancer. Let's see you in 6 months. Now you're walking around with this fear of like, is this spreading? So I don't know that, I think that people eventually do cave into going to treatment because the fear of it spreading is in the back of their head. I think that cancer diagnosis can be, obviously, it's a very anxiety producing, it's very, the rug is being pulled out from underneath you. And some people, I find that they find very empowered, like they're ready to make some changes. They're ready to take their health seriously. They're ready to prioritize themselves. So there is a lot of positive. I mean, I speak to lots of breast cancer thrivers, and on my podcast, The Girlfriend's Guide to Breast Cancer, and all of them come out with more purpose, they realize that they weren't prioritizing themselves. They weren't taking their health seriously. And it was like the wake up call that they needed. So not to say I think everything happens for a reason. It's hard when it comes to cancer, but maybe this gives you more purpose that you needed that you needed that you didn't have before. So I think it's a lot, like you said, your husband, his attitude is everything, and what you choose to do with this information is how you will thrive after breast cancer.
So then I had a different guest as well. I have so many guests talking about this topic, and she mentioned about the new scans, the new mammograms. And again, this is a while back, so I don't even remember. I would say maybe 2 years back. And she said the new ones have even more radiation than the older versions. Is that true?
No, so the digital breast tomosynthesis is equivalent to the same dose of regular 2D mammogram. When we used to do it, we would do a 2D and a 3D. So when 3D was coming out, they were doing a double mammogram. They were doing a 2D and a 3D, which was essentially like a double radiation dose. But now most places have gotten rid of the 2D completely. We only do a 3D. So now it's equivalent to the same radiation dose. So if anything, it's lower, and it lowers our callback rate and improves our cancer detection rate. So we might be able to call you back less because we have the 3D mammography. So in the end, it's a savings but again, it's a 3D mammography is the same dose as a 2D mammogram. The double radiation dose was when they were doing both of them, when we were trying to establish that digital breast tomosynthesis or 3D mammography can actually detect the microcalcifications of DCIS. Now it's been established, and most places are just doing a 3D.
Okay, most places in America are doing it now, 3D, as you're saying.
that
So,
I am aware of. Yeah.
okay, so if somebody's listening now and says, "Okay, I'm going to go for my mammogram," they should really be asking, double checking. It's a 3D, then a 2D. It'll be better.
Yeah. And only a 3D. You don't need a 2D and a 3D.
Okay, only well, yeah. Oh, I mean, would that happen on the same day, or would that be on a different two
Yeah, it happened at the
days?
same time. Like it would happen at the same exact time. Yeah.
Okay, just super interesting. So then you're saying then, so maybe, okay, maybe she was looking at the older stuff, or maybe she was thinking
Yeah.
about there was a 2D plus a 3D. And I didn't even go back
Yeah.
and listen to that, but I do remember her saying something about that. Okay, let me just double check. I want to make sure I've got, I've had so many questions. Oh, yeah, there were, so some people, like my husband, doesn't like to go to doctors. He's like, if you go, you're going to find something. I'd rather just not know, kind of a thing. And there's some people who maybe think about that with their breasts and say, you know what, I just don't even want to know because, yeah, they're worried about, yeah, finding. I guess that's why people don't take some DNA tests as well. But what do you would say
Mhm.
to somebody because, yeah, they're worried about being overtreated or finding something?
Knowledge is power. I think that when you go in for an imaging test, it can be scary, of course, what they're going to find. About 10% of people. So I just want to go back to like the mammography numbers. So of mammogram, when you get a mammogram, 10% of people are called back from the mammogram. Okay. So let's say 100 women come in for a mammogram, 10 of them will be called back. Six of the women will come back and they'll be told everything is normal. There's nothing to worry about. The other two women will be told that it's probably benign, that it's something that is less than a 2% chance of it being cancer. We follow it every 6 months for 2 years, and then we prove that it's stable, and then we bless it. The other 2%, the other two people of the 10 that got called back will need a biopsy. Of the biopsies we do, we talked about this, that 80% of the biopsies we do are benign. And this is because there's a lot of overlap with how cancers look and how benign masses can often look. So that's why we have those numbers. But like I said, 80% of them will come back benign, 20% of them will come back cancer, meaning statistically, like they're not going to find cancer on your mammogram at a single point in time, but at one point they will. And I think that for anyone who's listening and might be scared of coming in, knowledge is power. The earlier we could find your cancer diagnosis, the better outcomes you're going to have, the more options you're going to have for treatment, the less aggressive treatment you're going to need, and overall, the better quality of life. So, not seeing it doesn't make it mean that it's not there. So, if you don't look, it doesn't mean their breast cancer is not there. It just means that we haven't seen it yet. And it might be good in the short term that you don't know that you have breast cancer and you're kind of living blissfully. But at some point, that cancer is going to become evident, either clinically. At that point, it's going to be much bigger than it would have been if we caught it originally on the screening mammogram. So I really just encourage people to, I understand that screening tests are unpleasant. Like you're going in to find out if you have cancer. Nobody really wants to know if they have cancer. But at the end of the day, you probably do because like I said, it will just improve your outcomes overall and increase your likelihood of survival. So.
What about what we talked a lot about the calcifications? Why? So ultrasound, and actually, I have in my notes for some reason that my MRI does pick up microcalcifications. I don't even remember where I got that from, but you said it's not true, right? Even with the contrast,
Yeah.
right? So in ultrasounds, they don't see the microcalcifications, do they? Or they don't? They don't.
And ultrasound is really no, and ultrasound's good at picking up masses and cysts and telling if something is cystic or solid. And like I said, it can get through that. It uses sound waves to penetrate through the breast tissue. So it's good that it can see through the breast tissue, but it can't pick up the calcifications.
So the
So if
only
someone's
one is
doing that for screening,
yeah.
yeah, the only one that really can pick up microcalcifications that is commercially available now is mammography.
Is there a difference between the calcifications and microcalcifications? It's just a size thing that you're going to pick up
So
something earlier.
yeah, so there's lots of different types of breast calcifications. There's actually 14 different types. 10 of them are benign, 4 of them are cancer. And they're usually like these fine linear branching. They can be a little coarse sometimes, but it's usually this kind of amorphous calcifications that are new or increasing, and that's what catches our attention. And that's why we will then biopsy them, and that alerts us that it usually can be a sign of cancer. And we see a lot of cancers. I even posted a reel about all the different types of cancers that people of calcifications that we can find on a mammogram, and the amount of people that were commenting of like, I had microcalcifications, they were invasive ductal. Like, it's not just DCIS, and it's a lot of these are screen detected cancers. Sometimes the personal experiences like that you hear are just, there's so many personal experiences of where their cancer was caught early on a mammogram, and it's hard to really combat that. Like, those people truly believe, and I do believe as well, that their lives were saved by a mammogram. That's how their cancer was caught.
Calcifications are just small tumors, or what are they? What are they other than?
They're small Yeah, there's small calcium deposits in the breast, and lots of things can cause calcifications. Like surgery can cause fat necrosis, which can look like coarse heterogeneous calcifications. We spend 6 years in radiology residency and one in fellowship learning all about the different types of calcifications, and not all of them are cancer. The ones that you like, the bigger coarse ones that you could see on an ultrasound, those don't mean anything. Those aren't the ones we're looking for. The small microcalcifications, the fine linear branching, those we can't see on an ultrasound, on an MRI that I'm aware of. Those are the ones that really are the concerning ones. And that's what we can only really see on a mammogram at this point.
Did you hear about the ARIA test or the tear
I
test?
have,
Because that's
yeah,
detect very early breast cancer, but not the late advanced cancer. What do you think of that?
yeah. So that is a test that tests your tears. I don't know the data offhand of how sensitive that is.
Just so people know, sorry to interrupt, because they're knowing what
Yeah.
is this ARIA? It's just a little piece of
Yeah.
paper you put in your tear and it picks up two proteins that evidently are when you have cancer, they spit out these two proteins. Is that right?
That's what it claims to do. I don't know how sensitive it is, meaning like if you have cancer, how likely is it to pick it up? And if you have a positive test, like what happens next? Like, do you go in and get a mammogram?
Yeah.
Um,
Yeah. It's not a screening. It's not, it's just and again, an add-on, like for the early,
yeah.
like, since you said, oh, we can't, if somebody said, I'm going to get an MRI, but they don't take the microcalcifications, maybe they could add on the ARIA to find that.
Yeah. I think it's an option. I guess I do think that people need some type of breast cancer screening,
Mhm.
whatever that looks like for you. I myself and many other medical societies and most other doctors will recommend an annual screening mammogram. If you and adding on ultrasound or MRI if you have dense breast tissue. Now, if you are of the camp that does not believe that mammograms are important, that they cause cancer, then maybe mammogram isn't for you. But I still would really highly recommend that you're doing an ultrasound or an MRI. Maybe you want to add an ARIA test as well, something to help us find your cancer. I don't know how well it works. I don't have the long-term data on that. I think you have to understand what we are not able to see from a mammogram, and hopefully by not getting a mammogram, and hopefully this conversation will kind of educate you on that, like what you could be missing by not doing a mammogram. But again, it's a personal choice. I'm not going to, I don't make money every time someone gets a mammogram. Like, that's not how this works, as opposed to some of these other places that are selling alternative tests to mammogram. They are completely financially incentivized. They are investors. There is a conflict of interest in a way of the way that this is being, it will never get covered insurance because it's literally like a conflict of interest.
And
They
the
are
ultrasound
selling.
too, the ultrasounds as well.
Ultrasound will be covered by insurance usually. It's usually covered if you have dense breast tissue, which you wouldn't know if you didn't get a mammogram. So I don't know how that's covered. Some of these HER-scan studies, these are not covered by insurance. These are mobile units that roll up to, I think one of your, Dr. Yorf talked about HER-scan. Radiologists have big problems with these companies like HER-scan that roll up in this ultrasound unit and they're reading it in a vacuum. You're getting an ultrasound in a vacuum. You're not comparing it to old studies. It's not being interpreted. I don't know what radiologists are interpreting these because no one that I know agrees with the way that HER-scan is run.
What, but isn't it have to be a radiologist still reading it or no? It's just, doesn't
I
it?
don't know. I mean, even when I go back to
Interpreting.
QT imaging, they say that a radiologist reads it. I know of no radiologists that support QT imaging. There I had a follower send me a report from a QT imaging site, and it was supposed to be read by a radiologist. And it was a family medicine doctor that did a course in QT imaging. That is not a radiologist. That is, so I think you have to know who's reading it
I
and
think
what
QT is so new. I think it's too
yeah.
new. There's only a few centers or something that, and just in case people don't know what QT scan, it's just another, you lay on a bed and you have a bed of warm water and it's like a 3D scan. You put your breast in this hole and it's supposed to be like a gentle experience, feels like a spa or something. Not the people who don't like the compression, they tend to talk about that experience, the experience being good. And evidently it's just so new that it's not accessible. And it's obviously has an extra cost. So, and I think that's what the advantage of a mammogram is, that it's widely available. Insurance pays for it. People have access to it. But yeah, just to explain, I wanted to, because we keep talking about the QT and I'm like, well, there's people who don't even know what this is, but I thought we had to
QT
explain
imaging
it.
is a fancy type of 3D ultrasound. And like I said, we've been using ultrasound for decades as a supplement to mammogram, but it does not replace mammography. Even on the website, QT imaging, it says QT imaging is not intended to replace mammography. So if it's being sold, I just think that people have to be really wary where they get their information from on social media. And if the person who's delivering this information is trying to sell them something, I think this is a really big problem. When marketing is so good, it can be easy to be sucked in and to think like, I want this test. This has no radiation and it's advertised as like 40 times the resolution of MRI, which that makes no sense.
Oh
It's an
yeah, that's
ultrasound.
it. It's not 40 times resolution of an
I don't know where
ultrasound
these
or
numbers are
mammogram.
being, it's an ultrasound. I
Oh,
don't know
sorry,
where
it
these
said this
numbers
said
are.
yeah, no, I
Yeah.
have it here. QT uses sound waves in a water bath, creating a 3D image without pain, compression, radiation. It's 20 minutes, 40 times the resolution of MRI, and it can
Yeah.
measure the volume of lesions. It looks at doubling time to see if you should go and get a mammogram or not after that. So 40 times the resolution of MRI.
I don't
That
know where those numbers came from. I mean, if that was the case, then we would all be using it. Like all the radiologists would be using it. No radiologists are on board. Like, I don't know, it's claimed that radiologists are reading this. I would love to see the board certification of the radiologist that is reading it. There was one big study on QT imaging and there was one radiologist on this study and they got paid $500,000 to be on the study. That is not typical. That is highly
I don't think
atypical
so. That
and
would be, that would be
unprofessional.
too much. I think that's a little
I
high.
mean, it should be a little bit of a red flag. And I just think that the way it's being marketed as this fancy new alternative, and it's like you said, it's not available. There's only 10 sites in the country. One happens to be in my backyard, which lucky me, I get to deal with this all the time, which is why it's so hot,
Go in there
so
and
present on
say,
my mind.
let me
But
go in and ask, or let me talk to the radiologist. It would be interesting to see.
yeah,
You'll know because
believe
it's
me,
right
they
there.
would love to have me. They would love to have me reading for them, but like I would only read what I think is appropriate to read. Like I went to a radiology conference and I went around and asked people, "What do you think of QT imaging?" They're like, "What?
I don't think they know
What
it.
is QT imaging?"
It's not. Yeah, I
No.
think it's just.
Which
It's. I mean, I don't want to. Maybe it'll be something. I don't know. I mean, maybe it will. Maybe it won't. I'm
maybe, and
sure
I'm
people said the
open
same
to
thing
learning
with.
new technologies.
I mean, when
I'm like,
mammogram came, yeah, when mammogram came out, was everybody embracing it, or were they like, no, it's radiation?
of
And then
course,
finally they
no,
got
there
understanding of
was
it.
it was the latter. Like it took time to like prove that like this could actually it took years and countless studies and showing that there is a utility and how what all the things that it catches and this is important. Like that's the stuff that we need. We need the long-term data and the efficacy and the safety over decades. And that's what a lot of these technologies, I'm open to new technologies. I would love to find breast cancer at its earliest stage, like contrast mammography, AI, all these things, they're going to make us better at finding breast cancers and not finding the things that are not important.
Yeah,
Uh,
that's the thing. I think that's the trouble. Like heard that argument as well, is like some of this technology is so good, it's just picking up everything
mm,
and then it's just too much. It's too good
mm,
in that sense. So it sounds like it's kind of the pendulum needs to swing in balance. And I've heard of the future. Maybe you go to all these conferences, you probably know more than I do, but I
mm.
heard that there's going to be like an in-body scan. You scan the whole body and it can see like plenty of stuff inside and without
Yeah.
feeling
I
without
mean,
any kind of invasion.
there's whole body MRI, which I also have very strong feelings against for the general public, because I think that, again, when you look at companies like Pronovo, which is like a whole body MRI, it costs like $2,500 out of pocket. It is one point in time. it is a false sense of reassurance, because if they see nothing in your in your breast, it doesn't mean you don't have DCIS. If they see nothing in your colon, it doesn't mean you have colon cancer, because there are better screening tests for those specific types of cancers. So, and the whole body MRI is done without contrast. It's one point in time. So just because you don't have cancer on this non-enhanced MRI of your whole body today doesn't mean you're not going to get it in a year or two. So are you going to pay $2,500 every year to get this whole body MRI? No, most people cannot do that. So I think that you have to look at why are you, yeah, it would be great to know at any point in time if you have cancer. I think for the most people, I don't know. Would you want to know that there's like a small low-grade cancer growing in your adrenal gland? Maybe, but
Well,
you
if
talk
it's
about
turning into something, yeah, but if it's not going to turn into something, then leave it alone. That's the whole argument. And then there's the whole false positives and false negatives with any test that we get.
Yeah.
Right?
Once you see something, you can't unsee it. So you either have to work it up either through follow-up or a biopsy, in some cases surgery. And many, like you talked about, the anxiety that comes along with the anxiety that comes along with having an abnormal test, needing a biopsy, waiting for the results. Yeah, all that stuff means something, and it's important. And we have to really look at that with every imaging test that we give and we get.
So you are, as a radiologist, you're in the room right next to this machine all the time, right? So you're the one who's running behind the wall, reading the studies and stuff.
Yeah, I'm not taking the picture. Yeah, I'm not taking the picture.
You're not taking the picture.
In most
Okay,
cases, I'm in my reading room.
So, well, anyways, you know a lot about radiation. Do you have any hacks that would offset if anybody's nervous or I'm going to go get it? Fine. Is there anything they can do to, I don't know, the little radiation that they get, can you offset it?
I think you are more in tune with the biohacking of what you could possibly do to minimize radiation. I've heard things. I don't necessarily know that they work, but certainly if it makes you feel better, go ahead and take the melatonin. Yeah, none of us do that. I'm curious what you have heard to lower your risk of radiation.
I have to do the research, because this is just stuff that I pick up from our guests, and they're the ones who do the research. But the latest one was brown algae. It's oh, wow, really? Brown algae is supposed to be very good at offsetting radiation. And then there's the whole stack of.
Then is that person then selling you the brown algae?
No, not at all.
Okay.
Not at all.
Because sometimes that's the case. If you take my supplement, I think that's,
all the supplements I've heard have never been people selling supplements.
I've heard of people taking iodine, of people taking melatonin. If that makes you feel better, certainly take it. But I don't know that it's going to do anything.
Yeah, well, we've got to go look at the study. I think it would be interesting. I mean, you should know. I mean, you should go, I've looked at the studies. Absolutely, they work. I'm going to take it. Or no, this is a bunch of bull. Or you know what? It may do a little bit. And because you'd be able to understand that, I think, more than anyone. So,
yeah. And listen, radiation from a mammogram is safe. We give it during pregnancy. It does not affect the fetus. We give it during breastfeeding. It is safe. So, a lot of times it's fears.
But I thought you couldn't do it, because I don't know, whenever I go into get a mammogram, that's are you pregnant? You better tell the technician you are. So you shouldn't get it.
No, we should know about it, but we usually try to avoid it during the first trimester when the baby is developing. But you could certainly get a mammogram while you're pregnant. You heard it here first. Second and third trimester, not a problem. First trimester, probably not a problem, but we still.
Why wouldn't she be able to go in any of the different trimester?
Well, I mean, the fear of radiation is that it could possibly damage the developing tissue. So that's why we try to wait for the second trimester when things are fully formed, just growing. But the amount of radiation to a fetus is incredibly low. You've got the sac, you've got the fluid. It's all scatter radiation from the breast. It's not even, so we don't.
But it shouldn't matter for anybody. I mean, honestly, if it's that low, then you can go at any time in your pregnancy, which
technically,
then they should remove that, because then then that brings fear. If they think it's not good for the third trimester, then maybe it's not good for me. Or that's where it's better just to leave off that label and it let people, because then they just start thinking, okay, then something there, right?
We do try to avoid doing abdominal CT where there's radiation dose to the belly, but even that is very low dose. But We're always trying to minimize radiation dose whenever possible, especially if you're pregnant. So sometimes we'll start with an MRI first or even an ultrasound in those cases where they're pregnant. But mammogram is different. Mammogram is a low dose X-ray to the breast, not involving the abdomen at all. We're not imaging the abdomen.
Okay.
So it would be a
Well,
concern.
I think we covered a lot.
I'm exhausted.
I know. I hope I wasn't too hard on you. I'm just the messenger.
I know, and I hope I did it justice. Like, I hope that people listening to this, I'm not trying to sell you on a mammogram. I am trying to sell you on breast cancer screening. I think it's appropriate. I want you to understand why we do mammograms, which is to find the microcalcifications that often are the first signs of cancer that can't be seen on the other sorts of imaging studies. So it's just something to consider. And if you've heard this and listened to all this and you still decide mammograms aren't for you, please go get an ultrasound or MRI. Do your self breast exam, take your breast health seriously in other ways.
Right. I'm going to have links to your Instagram, the Booby Docs, and your podcast, which I just started listening to, and I'm really excited to listen more. It's called The Girlfriend's Guide to Breast Cancer, you and your bestie. And then you've got your website. Well, I also have your email, theboobydocs@gmail.com, and your website. So thank you so much again for your time. It's been wonderful to have you and give us another perspective.